pass it back to you to lead us through the next section.
All right. So thank you everyone for sticking around, and I hope you've enjoyed your conversations in the breakout rooms as we did. And I'd like to invite back our panelists, or if the breakout rooms elected someone else to represent the group, to brief us on the main takeaways of the conversations in your rooms. Nia, I know you. I was with you, so.
I know. Yeah. So first of all, I'd like to thank the group that was in my room. Great conversation, great discussion. So our topic was, just in case, community strategy and action that were successful in addressing health equity, mainly on the social determinants of health. How did that impact our community? And then the long-term equity goal, hepatitis B space. So our conversation started out because it's social determinants of health. The question was on different models, like the health belief models and all that, like how it was utilized for reaching community, right, for education and all of those kind of things. So question was asked and I did answer. We did follow the health belief model, especially during COVID-19, where people did not trust the vaccine, and also we have a highly religious group. For Pacific Islander, we believe God have a time for you to born and then die, right? So they're like, if I die, I'm okay, and all of those kind of things. So we went through a lot of that. And at the end of the day, what we did was we engaged our faith-based leaders and then have long discussion. And then to that end, just skip all the stories. At the end, Native Hawaiian Pacific Islanders have one of the highest vaccination rate in other ethnic group in so many of the states, right? So we went high in death rates to high vaccination rate. And part of it is that we do use models like the health belief model, but at the same time, we lean on to our culture, I'm health literacy, I'm a health communication person. So, but integrated that in language, culture, and then all of those things. So that was part of it. And then that's how we handle culture and language as a social determinants of health. The other question was complicated, right? And how to enter into community, how to work with communities to advance hepatitis B, anything, right? You know what I mean? Like policy or project, because sometimes community, they're like, oh, we get tired of all of this work that we need to do at the same time. And, so at the end, so that was the question, how do we enter into community, and also how to sustain it? They'd be excited for about 2 or 3 sessions or a month or 2. And then after that, they ghost you, right? When you call them back to come back. So through that conversation, we talk about how to enter into community, right? So even though we have hepatitis B as something where that is our priority and whatever else, but we enter into Pacifica community, what you need to say is that we are going to connect. I know you have your own needs and all of that there, but what I'm going to do is I'm going to connect hepatitis B or TB into your needs, right? Whatever, because it's all connected, right? So when I enter into this space, I did a lot of cancer work and diabetes and all of that. So I connected to cancer, you know what I mean? Like hepatitis B is related to cancer and all of those kind of things. So all of those things, it comes in there. Also, they're testing you. When you come into community, they're looking at like, is this a transaction where you're going to give me money, I'm going to do this, grant end, and then it's done. Pacific Island people, we're not transaction people, we're relational people. So even though you have a grant that is transaction, you do not have to enter community with a narrative of transaction. You can enter into community with a narrative relationship. So saying that, I am going to try my best to make that connection, but I also going to look at, other things. So for me, I started my career out in infectious disease, hepatitis B, TB, and all that. Where I am right now, I do a lot more diabetes, cancer work. And the reason why, because every time I go into community, they keep on talking about their gout, their diabetes, and all of those things. So instead of me changing them, I change myself. I went and do diabetes work, but guess what? They all doing hepatitis B, TB work, and so it's more holistic. So that's an example on how we handle like all of those kind of issues in our community in different spaces. And I think that's it. And I think those are some of the issues. And I think the third one is how you enter into Department of Health, right? Because he's looking like that's another bet. So how, as a community-based organization or a program, how do you enter into a space of community-based organization, but also how to enter into Department of Health where hepatitis B is not a priority. It hasn't been a priority in a long time, or if ever, right? You know, we always had tobacco, whatever else. So we also did a nice discussion on how enter into those space. And then also just like, and it's the same strategy that we did in our discussion that we did for community, you need to connect what's in it for them, right? For hepatitis B, when we enter into that space, you let them know, like, if you let us do hepatitis B, it's going to help you your HIV/AIDS, which is always the richer brother with the nice car, right? You know, we can help with, cancer. We can help with all of this. So make that connection. So even though there are two separate examples, at the end of the day, at the core, the strategy is look out for what's in it for them also, right? And then have us make the connection. So that's, I think, anybody in my group that wanna, correct, add, or whatever, feel free to log in.
I think that was an awesome summary. Thanks, Naya. Diane.
Absolutely. I had to throw a heart up for you, Nia, and for your group for, what was it, not transaction? Oh my gosh, we have so many t-shirts coming out of today. Very exciting. Very exciting. So our group actually met and we talked about health equity in today's context, and ultimately what is the role of TB, Hep B in advancing efforts. So ultimately what we did was we really started from that kind of individual place of what have our experience has been, what do we witness on the ground in terms of, being problematic or positive, etc. And one, ultimately some initial thoughts we had were where we really need to address and highlight and center that stigma that does exist and it does impact, outcomes and all of that. Two, relatability is really important. Right, and ensuring that things are relatable and that they're understandable. And we've talked a lot this afternoon about language, and it's not just linguistic difference, but it's like access and doorways and opportunity, and really what the impacts are for everyone, not just solely individuals with a diagnosis, or solely individuals from one particular population, but it impacts everyone. So again, we started from this place of kind of values, interventions need, and we talked about putting everything in buckets, right? And one bucket was that things need to be inclusive, right? And some manners and methods that can be used are use of storytelling, recognition that value exists when we're talking about our family members. So whether it's a child or a grandparent or a couple of the examples that were given, but to really share, those stories there. Recognizing that the more that we collaborate, we can do more, we can be better, and using uplifting language, ensuring that resources and materials and information are available, again in other language, but again in accessible terms, and that they're community specific, and that there's also barriers within cultures and places that we're from, and recognizing and leaning into that discomfort. So that brings us to the next bucket, which is really seeing where we missed the boat, right? Seeing where we just did not get it right. Often we don't look at, our failures or missed opportunities, or where we leaned more into transaction more so than relationship, but we need to do that in order to be able to advance. So one thing that came up was the elevator pitch. It is customary when we're looking for funding to come up with that highlighted, abstract, that 30-second thing that says, this is what I need and this is what you'll give to me. And often it can really lie and be exact. It can cause turmoil for the populations we're serving, from the populations where we're from, right? And being real and transparent too. Again, often we try to get through these interventions and say, we're going to achieve X, Y, and Z. We don't give that space where the community may not want the thing that we're doing or how we're approaching it, and we don't have those doorways for that. Recognizing too the challenges of things like paternalism, right? This is the intervention we're putting on you versus this is what is needed and is culturally appropriate for who you are and where you are. Also recognizing that grant management and raising funds is as much of an intervention as the population specific stuff is, right? We think about, groups we want to reach and what we want to solve, but often behind us, there's this thing where we only got a mini grant for 10 months. right? Or we only got a thing to do something very, very slim, and recognizing that there are some organizations and agencies that are doing this, and that's been their core focus. So being able to, again, collaborate, figure it out, and advance like our body of knowledge, our awareness of how to do that. But again, recognizing that grants that fund are also their own intervention themselves. Let's see. There's another bucket about what we can do. And I think that's really, really important, is again, knowing what our obstacles and opportunities are, gathering and streamlining our resources. So building a body of knowledge so that things can become, again, replicable. And that's as much, again, population facing as it is, grant development. Center and recognizing the individual as a best practice. Again, not us, this is comfortable for me, this is low hanging fruit. That's very disrespectful, but that this is what we can do to truly advance and be respectful and positive for the populations we're serving. And, recognizing that reduces harm as well. We're reducing harm by centering the individual in the populations. The baby in the background thinks so too. And finally, leaning into silences. Public health is notoriously white privilege and has a way of speaking. Bell Hooks used to call it legitimized reward speak, a very specific and appropriate and only one right way of communicating. We have to move away from that. It is very exclusive to the populations we serve. It is very exclusive to honestly everybody. And understanding when we come and we have all of these different people at the table who, maybe you're a physician, maybe you're whatever you may be, but some folks are quiet. And we have to understand why. Have we taken that space away from them to lean in to really help drive an intervention? Or, just recognizing that the silence is something too. And continue dialogue. That was one of the last things we talked about, is right now, today, we're all from different places. It's lunchtime somewhere, dinner time somewhere else. And this is very, very cool. All of the ideas that we've been able to generate are just from people who've never met each other before. We need to continue to have these types of conversations because the innovation that comes out of it is very wonderful. That's what we talked about.
These are all great points, and I'm trying to take notes. Excellent and very valuable. Thank you so much. I don't know. We also have Shioma.
So, I can actually report back for Shioma's group. Yasmin, thank you. So hi everyone, my name is Beatrice. I'm from the HUPFI Foundation, and I was the note taker for Shioma's group. And I will just do a quick summary of what we talked about. So the main focus of the group was health equity in today's context. So we just kind of talked first about what resonated with folks most from the panel discussion, and what thoughts people had about health equity. And a big takeaway was sustainability kind of after COVID. So COVID, as has been much discussed, highlighted a lot of the gaps that that are in healthcare in general, and community-based organizations really picked up the ball with that. But money is now running out, and so we really need to focus on making this more sustainable, but also speaking about how grant funding is not the answer. It needs to be continuous funding, and not a short-term solution. But also thinking about so many people have, or it's been much discussed that how to leverage the infrastructure that we built up during COVID, and actually reflecting that maybe we didn't do as good of a job at this. And so there really needs to be a long-term plan for, for funding and sustainability, which is going to be really challenging. Also highlighting that there is a lot of money to be had, that, in the pandemic, seemingly trillions of dollars came out of nowhere. So there isn't a shortage of funds. And also, policies can shift easily when, they're not static, as can sometimes be, as it can sometimes seem. So there is funding and policy changes to be had, but they're, that's something we need to work toward and focus on. And also, communities know what to do and have throughout the pandemic, and hopefully beyond, will continue to do so with little to no oversight, as was discussed before. So the shift in power and letting go of ego is also a really crucial shift that needs to occur. And then another big focus that we had was community health workers and how they are a critical piece to health equity work. And they can really work to improve outcomes with chronic diseases, often more so than physicians themselves. But again, there's often not enough long-term sustainable funding for them. So community health workers really need to be elevated. They need to be, paid sustainably. And then we had a discussion about the need to institutionalize payment systems for CHWs and kind of the push and pull of that, because if community health workers do become part of a hospital system, for example, they can lose, they kind of get sucked into this institution and can kind of lose what makes their interactions with the community so important and on the ground. So trying to kind of navigate that a little bit. There was also discussion of certification of community health workers, as has been done in Massachusetts. And this can be kind of strategy for economic mobility. But it can also be a form of exclusion for folks who have lower levels of literacy. So just kind of the push and pull of that as well. But overall, these work, it was just really highlighted what an important tool these workers are for engaging with communities, serving as a referral source, receiving trainings, and there were examples of how CHWs, eventually rose up. For example, one in North Carolina became the director of a community-based organization. So that was another kind of important topic. And then finally, was just kind of taking lessons from different spaces and, making sure to highlight intersectionality. So lessons from COVID and also from the LGBTQ community, for example, which kind of started out doing direct work in communities and then eventually merged with other groups kind of doing other work in other areas, and eventually formed a larger intersectional project that was able to receive more resources and more a steadier stream of funding. And this was the Hawaii Health and Harm Reduction Center. So that example was given as well. So I think those were the three major takeaways we had. And if I missed anything, please, anyone, feel free to jump in.
Thank you, everyone. Thanks, Beatrice. Very important, and to the point about the funding and the available money. It is there. The money is there, but just needs to be tapped in the right way. And we'll definitely talk about this. Thanks, Beatrice. Shireen.
So our group, we focused on community-based strategies and social determinants of health and how to move forward under that umbrella. We had a very real discussion with some transparency. I think one of the many lessons that came out of COVID was the importance of communication, and it even spawned a new discipline, public health communication, because there were missteps in public health communication. And so we sort of looked at social and structural barriers that prevent the public health department and community-based organizations from working together. There was some painful discussions a bit about where public health didn't show up and what needed to happen, and the perceptions that each organization, public health versus community, needed to have and understand among themselves. So, for example, healthcare in general has sort of a top-down authoritarian feel to it in the past, where there was a doctor and a patient, and then you listen to what I said and you do it. And unfortunately, we've moved far away from that. That it's a collaborative, that the patient has a very strong and important input on their care. And that same understanding is with public health departments and community organizations. Community organizations know their communities best, and public health departments and any large organization would it would be apropos and right to listen to those organizations in order to have the best impact. So we talked about, so for example, social barriers, the determinants of health, and how public health departments, community-based organizations could better leverage our understanding of finances and housing and clean air in order to improve a population, and maybe the more structural barriers like the roots of a tree. How can we build those structures better? And I think that what came out of that was, and then we talked about what strategies could we use moving forward to improve communications between public health departments and community-based organizations, how to get those two organizations to the table more frequently. And what we felt was there has to be a willingness and a commitment. Let me just get my notes. Trust, there has to be a reaching out, there has to be an awareness and a commitment to do so. And that's pretty much how the 3 points that we had.
Awesome. Thank you so much. These are all great insights, and thanks everyone for really staying around. I'll just try to reiterate a quick summary. We learned about the intersectionality between tuberculosis and hepatitis B and the benefits of collective action and how this is achievable through the community lens and taking a holistic approach, taking the full scope or the 360 picture of the community that we serve, and not just the issue that we're trying to work on because we have funding for, and through honest and transparent conversations with the community and the partners as well working with us. We also learned that there are pillars for success of community-based interventions. Some of them are involving all stakeholders on the table, and we've learned, or we might be out of the dark and hard time of COVID-19, we had the time to sit together and join hands or think about what we haven't seen or learned about the community we serve before, the importance of giving the lead to communities and let them lead interventions, avoid paternalism in intervention design and implementation, acknowledging the barriers and failures to avoid them in the future. And what really sticks with me is identifying the value of the family and the community value at best. While each of the social determinants of health has a different magnitude of an impact on health, we learn that those dimensions impact each other. For example, stigma negatively affects mental and physical health, both directly and by creating inequities across all of these dimensions. We've also learned about the importance of sustaining the infrastructure and momentum that we've built through or during the COVID-19. And I think this will be a big part of tomorrow's discussion. So I'll not delve very much into that, but communication is a critical piece, and money is there if there is a political will. The importance of communication and trust between partners, and especially health departments and funding agencies. The importance of community health workers and their role in the community, and the role of using community health workers and leveraging the role of the community. We also learned about the inequities that occur within each group. For example, there is difference among immigrants or immigrant population based on how long they've been in the country, the language they speak, immigration status, and how that affects their access to care and access to and their health outcomes. We've also learned about the importance of data and how data help shape the public health response and the community-based interventions. We've learned so much. There's much more. I just, and considering the time of everyone, I'll stop here. But I am very honored and appreciative of all the valuable insights that you've shared with us. Thank you, Shioma, Nia, Diane, and Cherie. Thank you so much for your valuable insights. And thank you everyone for joining us for the second day of the mini